Now I'm gonna join Andreas Baumbach in London again, and together we will be doing a wrap-up of the sessions of the day. So we will try to give you our feedback on this wonderful day. Andreas, nice to see you again. What are your thoughts about the first part of these sessions today?
I'll break protocol, Thomas. I'll ask you a question first, because I'm still taken by the late breakers. Let's take that slide away. You are a surgeon, I'm an interventional cardiologist. What do you make of the NOTION trial? It's the first time we have 8 years of aortic valve versus percutaneous valve next to each other. How reassuring are these data for us? After that, I'll tell you what I thought about my first session.
So, Andrea, this is a trap, but I take it very seriously, and yeah, very seriously. I think this is, Lars should be congratulated with his colleagues from Northern Europe to have been able to conduct these studies. I think this is very encouraging, and it really highlight and confirm what we see on daily basis. Few patients are coming back with the self-expandable devices because of device failure. This is very important to note. However, I think you know that we work in a hard team, and it's our responsibility and duty to evaluate and keep on evaluating. For me, there are two limitations for this study, but which are, again, very, very encouraging. First one is that this study meant to include patients 70 years and above, and if you look at the mean age, it was 79 years old. So before moving, and I think we need more courageous studies to assess not only high-risk patients, but talk really about the cutoff of age. This is very important. And the other one is also, at 8 years, few patients have been followed so far. So in summary, it's a very encouraging study with very encouraging results, but we still have to wait. And also, I think in the future, we have to, in the surgical arm, to use valves that have the longer-term follow-up. This is very important in order to convince not only both of us who believe in TAVI, but all the community that TAVI is durable and TAVI could be expanded and extended to younger patients. But now it's my turn to ask you.
Thank you.
You have to do your job and tell me what you think about your session.
I will. Okay, let's go back to the slide. The first part of the day. This was the tricuspid day. And we were looking at imaging and innovation and a case. What I took away is, you know, a lot of great information and very promising results. Imaging. I can see we are getting much better at classifying tricuspid disease, tricuspid regurgitation. New classification system has been in place for a while, but it's now really linked to mortality. We're getting better at identifying the right time point, maybe, for intervention. So massive progress in imaging. That's what I learned from the first session. In the spotlight, we had a review of the transcatheter intervention options. Where are we in 2020? What I learned is that we have come a long way. There is plenty of new systems out there that look promising. Some of them have been used in man. Some of them have larger series now. And what is striking is that if they work at very low procedural risk. There's hardly any mortality. There's not a lot of complications in this transvenous, usually, procedure. So I learned that we've come a long way in tricuspid intervention, and that this is coming. This is coming to your cath lab fairly soon. I also learned little things, like why is it that the regurgitation treatment is not linear? Why is it that some patients all of a sudden have a massive improvement in their symptoms by improving renal perfusion, for example, making patients that were medication resistant beforehand, they all of a sudden the diuretics work again and they lose fluid. That was sort of an aha moment. Why does it work if we reduce tricuspid regurgitation? Little things. And then, of course, finally, the highlight of the first half of the day was the case, a transvenous procedure for a problem that a couple of years ago, would still have been a really, really big problem, a failed bioprosthesis in the tricuspid position. And in 20, 25 minutes or so, they put another valve in through the vein, made it look really easy, but it was very well prepared, and of course, excellent operators, and giving the patient a new lease of life in no time. So I took away tricuspid intervention is here to stay, and it's a fantastic development that we will be watching and following in this meeting over the next years. How about you? We hand it over to you and the surgical case. What were your highlights?
I also enjoyed pretty much watching and being the anchorman of 3 different sessions. The first one was the demonstration that we should do learning and teaching without borders, and this was a partners in learning session in collaboration with TCT, and it covered 3 important elements. The first one presented by Francesco Maisano about the anatomy. The second one about an update or the best standards today in terms of tricuspid valve surgery, how we can do it. And then the last one by Scott Lim about the development of intervention treatments in the area of tricuspid, as you have been mentioning. I think the 3 presentations converge and are an opportunity for physicians, but also engineers and industry to understand all the needs. I think one view is not enough, but putting together all these knowledges is very important to improve and keep on improving the field. So we all learned a lot out of these clear and concise presentations. The second part was after the Leipzig team presented the case of the patients they have been treating, they showed the beautiful, elegant, minimally invasive biomini-thoracotomy, videoscopy-guided tricuspid valve surgery. And Nicolas Dumontet, who was sitting next to me, he highlighted the importance of the interventional cardiologists, but also in the audience, all those who don't have access to the operating room, to understand the anatomy of the tricuspid valve, to see how thin is the annulus, to see how thin are the leaflets of the tricuspid valve. I think this is a very important, but because once you have the catheter in your hands, you just have to close your eyes and imagine that you are really doing this lively, macroscopically within a patient, and this, I can tell you, it will change completely your understanding and approach. And this is of a great value, and this is one of a kind that PCR is offering today. And the last part was a TAVI dedicated session, I would say. We had an amazing update about the Notion trial at 8 years from Lars Sandergaard, so it's very promising, it's very encouraging, and durability, just about waiting the years and the many years before saying this will last for 10, 15, and 20 years. But we have to be courageous and conduct more studies in younger patients. This is where we want to go, all of us, in the confinement of our team. We had also an excellent presentation about the cost effectiveness of TAVI, but I think it was somehow frustrating to see that the gap between TAVR and SAVR was cost effectiveness was not in favor of TAVR because of the price of the valve itself. So this has to be interpreted in with this view. And at the end, Lars Sandergaard presented again HYDRA valve, which is about the innovation, one of the latest valves in the field. So me too, I enjoyed pretty much being able to cover all these sessions with you, Andreas, and all our colleagues, Nicolas and Didier here in Toulouse. And that's it.